Hello and good evening, everyone. It's 7 p.m. UK time, and so it is time to start our live event. Today, we are starting a little bit earlier. As you know, this is our second webinar tonight, so I'm very happy to be back here with you. And I am your host, Caroline, as always. And tonight, again, we have another topic and another special guest in our Stronger Together online events. And as you already can see, today we have another special top fertility expert. This time, this is Dr. Zineb Meski from IVF-Spain Madrid. How are you feeling, Dr. Meski, tonight?
Hi, Caroline. Thank you for your introduction. Well, I'm feeling great. I can't wait to begin this webinar tonight and see if the patients um, ask some questions and try to answer all the questions.
Wonderful. Thank you so much. And of course, we will definitely start with the presentation on alternative family models for women. And afterwards, as always, it will be time for your questions. So remember, you can type the questions in the chat section. You can do it now during the presentation or later on so that Dr. Meski can help you out with all of those questions. And before we start, as always, let me tell you that we are here every single day from Monday to Friday, usually at 8 p.m. UK time, today at 7 p.m. UK time. And we are just simply here to support you, to help you out with your questions, to provide you with as many fertility experts as we can so that you can find out and you can simply meet top fertility experts in the IVF field. And as always, there are so many ambassadors and partners that are supporting this Stronger Together initiative. So thank you for their support as well. And yes, it is time to start the presentation. And Dr. Meski, are you ready to begin with it?
Yes, Caroline, I
Excellent.
am.
Thank you so much. Then go ahead.
Okay. Well, as Caroline nicely introduced me before, I'm Dr. Zineb Meski. I'm a fertility specialist at IVF-Spain Madrid. And I'm very happy to be here tonight to present this webinar about alternative family models for women. So we're going to start by a quick briefing about the law in Spain. So since 1988, the IVF legislation changed a lot in Spain. So they allowed the latest technology and also more treatment options for heterosexual couples, homosexual couples, and single women. Especially since 2006, the law for same-sex female couples have been approved, and that's what is called ROPA. So ROPA stands for reception of the oocytes from the partner. So the requirements is for the couple to be married or domestic, to be in a domestic partnership. So that's just because usually when you receive the eggs from a donor, according to the Spanish law, it has to be strictly anonymous. So since here we are making an exception for married women, a same-sex female couple, that's why we need them to be married, because we are getting eggs from a known person. In this special case, from your wife or your partnership. So there are some timing for these treatments, some steps. So the procedure of the treatment is about the synchronizing of both cycles. So that's the timing of the cycles. We need to stimulate the woman who will give the egg. That's we're going to call her the donor from now. And at the same time, we're going to do the preparation of the endometrium of the partner who will receive the eggs. So that will be the recipient. So there will be a donor and a recipient. So while we are going to stimulate the donor, Usually it's the younger woman, or the woman who has the better ovarian reserve. She will get her stimulation treatment in order to extract the eggs. And at the end, once we do the egg retrieval, we are going to fertilize the eggs by ICSI with a sperm donor. And then we are going to leave those embryos to develop in an incubator to the blastocyst stage. That means a day 5 or a day 6 embryo. So we can do an embryo transfer to the recipient. So that's why we have to synchronize both cycles, so we can do a fresh embryo transfer. So when we do the egg retrieval for the donor, the recipient has to be ready. That means that the endometrium has to be ready for the embryo transfer. So we recommend that the couple stays in Madrid for around 7 days. So that's the required stay in Madrid, because between the day of the egg retrieval and the day of the embryo transfer, as I said before, we need to leave the embryo inside the incubator for 5 or 6 days. So that's why an average of 7 days is required in Madrid. Okay. So there are, of course, many treatment options. There's the simple IVF with the sperm donation, but there are also other options. So that will be, of course, according to the indication of your physician, of your doctor, that will give you the best treatment for you, the personalized treatment for you. So there's also the IVF with EGS, that means the pre-implantational genetic screening, and of course with sperm donor. So that's an IVF, but at the end, instead of transferring the embryos at a blastocyst stage, what we are going to do is analyze those embryos, analyze them genetically to see if there is any genetic abnormality to the embryos before we transfer it. So we are not going to be able to do a fresh embryo transfer in that case, because when we analyze the embryo, we do a little biopsy of the embryo to take out some cells. That's why a blastocyst stage is necessary, because we are going to have a more developed embryo with more cells. And the biopsy is going to be also more safe for the embryo, because we are going to be able to distinguish between the inner mass, the inner cellular mass, and also the rest of the cells, who is going to be the placenta. That's the trophoblast. So we are going to take out cells only from the outside of the embryo. We're not going to to do the biopsy on the inner mass. Okay, so we are just going to take out some cells from the trophoblast, and we are not going to be able to do a fresh embryo transfer, because we have to wait for the results, and the results can take sometimes about 2 to 3 weeks. So that's why we have to freeze all the embryos. We cannot leave the embryos for more than 6 days inside an incubator. So we'll have to freeze them, all the embryos, and then wait for the result. And once we have the result, we will do the embryo transfer. Okay? So in this special case, there's no need for the patients to be synchronized, because we are going to do first the stimulation of the woman who's going to be the donor, and then we are going to do the embryo transfer in a second phase. So there's no need for both women to be synchronized. And there's another option, and that's the embryo banking with sperm donation. So that's for women with a low ovarian reserve. So what's embryo banking? Embryo banking is to accumulate embryos. Sometimes when a woman has a low ovarian reserve, you cannot take out many eggs from a first cycle. So you do the stimulation, and after the stimulation, you do the egg retrieval, and you get around 4 or 5 eggs, for example. So when you get this amount of eggs, you cannot expect to have too many embryos, because there's a natural selection when the blastocyst stage is done. It means that the culture of the embryo during those 5 days will allow us to get a natural selection of the embryos. Only the strongest ones and the better quality of the embryos is going to get to the blastocyst stage. So if we have a small amount of eggs, we will have a small amount of embryos, because only around 50% of all the embryos are going to make it to the blastocyst stage. So embryo banking is to do first a cycle of in vitro fertilization, get the embryos, and we will not do the embryo transfer. We will accumulate, freeze all these embryos, and we'll do another cycle to get more embryos. So it can be 2 cycles or 3 cycles of stimulation to get a good amount of embryos. And why do we do this accumulation of embryos? It's because we want to do a PGS at the end, just like the second option that I talked about earlier. That means the genetic, the pre-implantational genetic screening. So we need more embryos, because not all those embryos are going to be healthy or normal, or because we want to do more attempts. We want to accumulate these embryos and then transfer the embryos and have more attempts and more chances to get pregnant. So if the ovarian reserve is too low, we prefer to take out all the eggs first, extract the eggs, because that's what is going to be affected by time and age, and then do the embryo transfer. There's also several treatment options for the recipient, and basically there are 2. So it's the transfer of a fresh embryo. So that's when we do the synchronization of both cycles, because we want to transfer the embryo right after the egg retrieval. I mean, 5 days after the egg retrieval, without freezing the embryos. So usually we do that in classic IVF and with the sperm donation. And when we have a good amount of eggs and a good amount of embryos, we do a fresh embryo transfer. And the other option is a delayed transfer of a frozen embryo. So that allows us a little bit more of flexibility in terms of scheduling the treatment, because we are not, we don't have to synchronize both cycles, but it's done in some special occasion, like doing PGS, for example, because we are not going to have the result until 2 weeks, after 2 weeks. Or for a special, some special occasion, like the recipient cannot do the embryo transfer because she didn't get a good preparation of her endometrium, or because she couldn't be here for the embryo transfer. There are some exceptions for freezing all the embryos and doing a delayed transfer. Then we are going to talk about the sperm donor, because it's a very important part of these treatments. So IVF-Spain Madrid works with 3 different sperm banks. So there's the European sperm bank, there is Cryos, that's a Danish sperm bank, and there's the national sperm bank. So, of course, it's strictly anonymous. You cannot choose the donor. You won't know anything about the donor, but we will choose the donor for you according to your physical characteristics, your blood type, and also there are some preferences that you can tell us, like the color of the eyes, the skin, if you want the donor to be more like the donor, the egg donor, or the recipient, since the recipient is not going to give her her eggs. So these are the according to the law here in Spain, it's strictly anonymous. So these are the only things that you can really choose. You can choose the bank, but you cannot choose the donor, and you won't have any information about the donor. And of course, the donor won't have any information about you neither. So how do we organize the treatments? First, we do a first visit. So that could be that could take sometimes 2 hours, but it depends on how you feel about the treatment, how you feel about the whole consultation with the doctors, all the questions they can be answered during this first consult. But we will try to do a personalized treatment plan, because we think that not all women have the same metabolism. They don't have the same. They don't respond to the medication the same way. They don't have the same background. So we are going to try to personalize every treatment for every couple. Then once the treatment is confirmed, once you are ready, we will try to give you all the prescriptions for the medication, so you can buy the medication at home. And then we will give you also all the treatment plan, so you can schedule your ultrasound scans, you can schedule all your blood tests, everything, and send it back. So we have to we try to limit all these all the traveling, especially now with this COVID situation. So you can do everything possible by distance, and just be here for the end of the treatment. And we will tell you about all the next steps. We will give you all the schedule and the information. So once you start the treatment, we will tell you if there are any further analysis that have to be done, like an endometrium biopsy or a carrier screening genetic test, for example. So a carrier screening genetic test is a test to see if you are carrying any genetic disease or any mutation. And it's also done to the sperm donor. So there are some diseases that are always checked in the donor, in the sperm donor, but of course there are millions and millions of genetic diseases, and we cannot check them all. We are going to check the most common ones, like the cystic fibrosis, the Fragile X, for example. But if you wish to do further analysis to all genetic screening, to do all genetic diseases, sorry, you can do that. We can do that for you. And there's also a possibility to do a matching. That means you do the carrier screening genetic test. The donor does also a carrier screening genetic test. And then we cross the information and we do the matching to see if you do not carry the same disease, the same genetic abnormality. So those, we can see about those once we start the treatment. And then you start the stimulation from home with a personal support, as I said before. That could be via email or telephone or Skype. Now we have all these new technologies that can help us to communicate better. So I've talked about the ROPA mostly, but I know that there are also some single women, and that's just the same. It's the IVF with a sperm donor, and or if the ovarian reserve is too low, we can do also the embryo banking with the sperm donor. Or if it's really, really too low, then she can have an egg donation, and that means a double donation. So in that case, of course, the donor, the egg donor and the sperm donor will be strictly anonymous. But it's kind of the same treatment, and the only thing is that we don't have to synchronize two women. We just have to do the treatment for the single woman. So I think that that's pretty much what I had to say about these treatments. I'm sure you have lots of questions, and I will be very happy to answer them. So thank you very much for your attention.
And thank you so much, Dr. Meski, for your presentation, for explaining all the details already, of course. And yes, you are very right. It is definitely time to start our Q&A session. As you can see, there are a few questions ready. But of course, let me remind everyone that now our Q&A session is starting. So if you have any questions you would like to ask, go ahead and type those in so that Dr. Meski can help you out. And let's have a look. Of course, as I've mentioned, there are questions ready. And the first one is, which method do you use for PGS?
All right. Thank you, Maria, for your question. So we use the new generation tests for the PGS. So that means that we do a sequencing of the DNA, and it depends, of course, if we are going to do a PGS or a PGT for the aneuploidies. So aneuploidies is basically to look for the chromosomal abnormalities like the Down syndrome or any kind of trisomy. So that will be the PGS for aneuploidies. So that's the screening. And if we are going to look for a specific genetic disease like the cystic fibrosis or any other disease that is already known to be carried in the patient, we will use the new generation sequencing method.
And thank you so much for the very first question, of course, for explaining. And actually, there is another question in regards to PGS, so let me show you that one. Is there any other diagnosis method not so invasive for the PGS?
Okay, thank you, Cassandra. So you mean without doing the biopsy to the embryo? There is no other method, unfortunately. We need to take out some cells from the embryo to analyze those cells and to have some DNA of the embryo. So for now, that's the only method. There are some other methods, but it's not a PGS. That means that we are not going to know before the embryo transfer. That's the new no invasive methods for during the pregnancy. So we can do a blood test. That means that there is DNA of the embryo in the blood of the mother, of the bearing mother, but she will already be pregnant. So unfortunately, if there is a bad result or some abnormality during the pregnancy, then there is a decision that needs to be made to keep going with the pregnancy or terminate the pregnancy. So that's why we prefer to do the PGS, because it will be a diagnosis before we implant the embryo. And the only way to know that is to do the biopsy, but it's safe. That's why we need the embryo to get to the blastocyst stage. Otherwise, the embryo on day 3 will have very few cells. And if we take out 1 or 2 cells first, we take the risk that we won't have enough genetic material, DNA, to analyze, and the results will not be so reliable. And second, we can damage the embryo because he has only few cells, 8 cells, and if we take 1 or 2, it's a lot comparing to a blastocyst stage when usually they have around 200 cells. So it's a safe method.
And excellent. Thank you so much for another question. And of course, Dr. Meski, for your answer. And actually, once again, there was actually a follow-up from Maria. So let me go straight to that one. And of course, we will go back to the previous questions. And so with your PGS and GS, will the transfer be 1 month after the egg collection? Can that date be planned, or is it just down to when is best for your body?
Thank you, Maria. So when we do the PGS, the transfer can be, yes, it can be the month after the egg collection, because first we need to wait for the results. And as I said, it can take around 2 to 3 weeks to get them. So it's 3 weeks after the biopsy, and the egg collection is done 5 days before that. So if we do the maths, it's almost a month. So we can start doing the preparation for the embryo transfer before that. It depends on the period. Of course, all the treatments that I've talked about, they have to start with a period, ideally, but we can also trigger the period if it needs to be done, if we need to schedule the treatment for a specific date, and or just start with a birth control pill that with your period, so we can just pause your cycle, your natural cycle, and start whenever we want. So we don't need to depend on your period. So that date can be planned ahead of time. It's a little bit best to do it according to your body, but we will control your body with all the preparation. We will give you the medication so the endometrium gets thicker and your body gets prepared. So it's planned, actually.
And excellent. Thank you so much once again for your answer to this question. Now let's go to some on a different topic. So what about embryo adoption for single mother? Is there a long waiting list, and do you have embryos of various phenotypes?
Thank you, Emma. That's a very interesting question, actually. I didn't really talk about it, but it's also an option. When I said double donation, it means also embryo adoption. That could also be a good option for these women. So there is not a very long waiting list. It's really up to the embryos that are available now. So the patients that has already done treatments with us, and most of them got already pregnant and they don't want to use any more of their frozen embryos that are left, they get this option to donate them to other patients. So according to the Spanish law, they can only the patients that are under 35, female patients that are under 35, when they did their cycles with us, can donate these embryos. So they donate them, and we just need the authorization. So these patients need to sign all these consents so we can use those embryos for other women. So sometimes we have a number of embryos that are already available, but of course we need to match a little bit the phenotype. It's not, I mean, the law does not strictly say that we have to match the exact same phenotype, but we always have to respect the ethnicity at least, and try to respect some blood types, especially the most uncommon ones that can be a problem, like the negative rhesus blood types. So, but it's like secondary. It's not like when we do a research for a specific egg donor. There we have to respect all the phenotypes. But here it's a little bit different. We just try to get the closest patients to your ethnicity. And if there is an embryo that is available, we just assign that embryo to you and you can start right away. So I think that the longest waiting list that we had was about 3 months. So usually it doesn't exceed 3 months.
All right. Again, thank you so much for a thorough explanation to that one, and of course for your question. And actually, someone else is asking in regards to that: do you have embryos of black or mixed ethnicity? Is there a long waiting list? You mentioned that.
Well, actually, Margie, we do have some embryos that are generated from a black or mixed couples. So, as you know, IVF Spain is a group of clinics that are very open to the international patients. So we have all kind of ethnicities. We have several type of embryos that are listed in our embryo bank, and sometimes there could be a little bit of more waiting, but that's only because maybe there are several patients also. So usually it's not an issue. We do have a very wide range of ethnicities.
All right. Again, thank you so much for that. And of course, there's a thank you from our previous patient as well.
You're
And
welcome.
let's have a look at the next question that we have from Maria. After one egg retrieval, how fast can you do next stimulation in case of low amount of embryos?
Okay, thank you, Maria, for your question. This is a very interesting question also because sometimes patients do get a little bit confused about the timings and about all these side effects of the stimulation. So actually, we just need you to get your period again. We need to do a little checkup once you have your period after the egg retrieval. Usually it's a week after the egg retrieval. You'll get your period, and with that period, we'll do an ultrasound to make sure that everything is back to normal. And if you have no cysts, no side effects of the stimulation, we can start right away a second stimulation. So yes, a week after the egg retrieval, you get your period, and we can start the next stimulation.
Again, thank you so much for the explanation to this particular question. And next question is it possible to use my brother's sperm and a donor egg for my baby? I am single.
Thank you, Margie. Well, actually, here in Spain, you cannot use your brother's sperm, unfortunately. I'm sorry, because as I said, it has to be strictly anonymous. So, I mean, the same-sex couple women can use the eggs. It's not really considered as an egg donation because it's a married couple, as I said, or domestic partnership couple. But for sperm, it has to be an anonymous donor. So unfortunately, the law for now hasn't changed, and for the male couples, it's not possible yet. And even for the sperm donors, they have to be strictly anonymous.
All right. Again, thank you so much for explaining that once more, of course. And there are like two questions left. Okay, so we will be slowly finishing. But of course, if you have any questions left, this is your time to do so. Go ahead and type those in. And the question is right here. So, what would happen to the remaining frozen embryos in case the couple breaks up after the ROPA program?
Okay, thank you, Emma, for this question. It's a tricky one. So, well, actually, it's up to how the couple breaks up, really, because when you do, as I said before, the ROPA program is can only be done for a married couple or a domestic partnership. So they both need to sign the consents. So legally, all the embryos belong to both patients. So if a couple breaks up, after all, it's like a heterosexual couple. If the couple breaks up, they need to see if which one of them gets the custody of the embryos. So it could be an arrangement between the couple, or it could be something that could get a little bit complicated, and sometimes they're not allowed to use those embryos. Neither of them is allowed to use the embryos. So it's not really up to our clinic. It's up to the law and the lawyer's decision. But you have to know that if you do the treatment, both of women will sign the consents as if they were both the parents of the future child.
All right. So again, thank you so much for explaining how everything works. Yeah, definitely something to remember for sure. Thank you for that. Okay, let's have a look. Next question is, what are the rates for IVF double donation for a woman over 40?
Um, all right, Silviana. So usually age affects the quality of the eggs, the quantity and the quality of the eggs. So it doesn't really affect the uterus. I mean, it affects it, but not as much as the quality of the eggs. So if the woman is healthy, if all the blood tests, all the testings are normal, the success rates are the same for double donation for a woman over 40 or a woman under 40. And these success rates can go up to 75% because we are going to make sure that there is a good egg quality from the egg donor, and also a good sperm quality from the sperm donor. And it's only up to the uterus to be prepared and to have the best conditions for the embryos that will be generated from these double donation treatment to allow the embryo to implant. So we are going to make sure we do all the tests before transferring the embryos, and the success rates usually are very high.
All right. Again, thank you so much for your question, and of course for answering and explaining this to us as well. All right, so let's have a look. And of course, as you can see, there's a thank you from Silvana as well. And now a bit of a longer question for you. I have PCOS and have had cysts in the past. I'm on the birth control pill now in order to plan my IVF. Do I still need to do an ultrasound before starting the injections to see whether there might be any cyst, or won't there be any as I am on the pill and didn't have any cyst in the last ultrasound in summer?
Thank you, Maria, for this precise question. So actually, we always recommend to do an ultrasound before starting the injections, just to make sure there are no cysts. Usually, when you're on the pill, there's very low chances to have cysts, but sometimes it also happens. So we prefer to do that just to make sure there is absolutely nothing going on there before starting the stimulation, because if you have a cyst, that could interfere with all the stimulation, all the hormonal treatment. And when you do an IVF, you don't want to start with of the wrong foot, as we say. We just want you to start with the best conditions to get the best outcome from your stimulation. So even if you didn't have any cysts in the last ultrasound in summer, that was 2 months ago, and it can change from a cycle to another. So I would recommend to do that ultrasound before starting, just to make sure everything is fine.
And again, thank you so much for explanation to this one. And as well, there is a thank you from Maria to you right here.
Thank you. You're welcome.
And one more, actually, how much does NGS decrease the risk of miscarriage and a sick child?
Okay, so the PGS and the NGS method is quite reliable. Actually, it's like a 99% of reliable results. So it won't decrease it won't decrease the abnormalities. It will just give us the information. So it will just tell us which embryo is healthy and which one has an abnormality. So knowing that, when we do an embryo transfer, knowing that the embryo is healthy, doesn't have any of those genetic abnormalities, the risk decreases a lot of the risk of miscarriage, and of course will decrease a lot. I can't give you a number because you don't really get the chance to do the study between women that do the PGS and the risks of miscarriage. When you don't, it's really difficult to compare, because either you do the PGS, either you don't. With the same embryos, it's very tricky to do a study, but it does decrease the risk of miscarriage, because most of miscarriages, especially in women that are close to 40 years old, are caused by a genetic abnormality. You have also some issues. You can have also some issues with your coagulation, with your implantation window, with some other problems, other issues with your uterus, like polyps or fibroids. But the most common ones are the genetic abnormalities. As for a sick child, as I said, the PGS will only look for some specific genetic abnormalities, and we cannot look for all those genetic diseases. It's really impossible. So even if we do PGS, you can still have a sick child, but that would be due to other kind of genetic problems, not chromosomal structure or chromosomal number problems. It would be some genetic or mutations that, as I said, we cannot test all of them.
Again, thank you so much for another answer to the question. And let's have a look at the next one, sorry. And so could it be possible that donor embryos can be from couples both over 40? What are done with remaining embryos of couples of over 40 if they don't want to destroy them?
Okay, thank you, Margie. So it's really not possible for the donors of the embryos to be over 40, because, as I said, according to the law, at least the woman has to be under 35 to be allowed, to be authorized to donate her embryos. As for her partner, there are some tests that we will need to do, like karyotype, to see his chromosomes. So we need to make sure that this couple that is going to donate their embryos don't have any known genetic disease that can be transmitted to the embryo. And if there are over 40 and they cannot donate them to other couples, here in Spain, they are not allowed to destroy them. There is another option, and that's to donate them to investigation. But it's also tricky, because if there are no projects of investigation about embryos currently, sometimes it is a bit of a problem to donate them for investigation, because you need to have a project, a current project, so they can use those embryos. Otherwise, they'll just be frozen and waiting for a project to come.
All right. Again, thank you for that question, indeed, and thank you for the explanation. Definitely something interesting here as well.
Mm-hmm.
All right. Thank you. And one more question. It seems that it will be our last question. So let's have a look. What is the rate of genetic abnormality of the embryos for 40-year-old women?
Okay, thank you, Margie. So this is an interesting question, because we haven't talked much about the numbers, but there are some statistics there that are very interesting. So usually a woman of 40 years old will have around starting 35, at 35 years old, a woman will have a 60% chance to have healthy embryos. So 40% of the embryos are going to be healthy. Then, as she gets closer to 40, that range will decrease, the range of healthy embryos. So when she gets to 40 years old, usually it's around only 40% of the embryos, or even between 30 and 40% of the embryos are going to be healthy. That range gets reversed. So 40% is going to be healthy and 60% is going to be abnormal. If we simplify it, only 1 out of 4 embryos is going to be healthy, more or less. Of course, every woman is different. Every person has a different body, different metabolism. So the best way to know is to do that PGS. That's why we recommend to do the PGS in every woman that is 40 years old or beyond.
And excellent. Once again, thank you so much for your question. And as I've mentioned, it seems that this is our last question for today. So I would like to thank you already for joining us tonight, Dr. Meski. It's good to have you here. Thank you so much for bringing this topic, for explaining all those details and answering different questions indeed. And of course, thank you to all of you for joining us, for your questions. I'm sure it has been useful for you. And well, I can only say that, of course, there are some thank yous coming up right here, as you can see, Dr. Meski. So is there anything you would like to add?
Well, thank you very much, Caroline. It was really a pleasure for me to be here and to answer all these questions. I hope it was very useful and very helpful. And what I just wanted to add is that the best way to learn more about your fertility or your treatment options is to do a first consult. We have many options for that: Skype, Zoom. We have a lot of tools to do the first consult. You don't even have to be here. So if you need anything, just do a first consult. It can be with our clinic, with another clinic, but just do a first. That's the first step, is to do the first consult, and then from there you can think about it and do all the tests and schedule all your treatment. But you need to know first what is the best treatment for you, and that's with the first consult.
All right, excellent. Thank you so much. It's definitely a great finish for today. So thank you so much for that. And so, as you know, you can get in touch with IVF Spain Madrid and, of course, Dr. Meski, her team, and I'm sure they will be more than happy to assist you with more details to your questions. So I'm sure of that. And so this is it for today. Please remember this has been recorded. So, of course, it will be available tomorrow on our website, myivfanswers.com, but also on our YouTube channel. So I can only encourage you to simply follow us there and subscribe. So that way you will be notified that the new video has been uploaded. And as you know, we will be back here tomorrow. So again, just don't hesitate and simply try to register for our upcoming webinars. There are plenty more to come. And Dr. Meski, it has been a pleasure to have you for the first time with us, and I definitely hope it's not the last time. So have a lovely evening, everyone, or good day wherever you are. And Dr. Meski, again, thank you so much, and
Thank
have a
you,
pleasant
Caroline.
evening.
Thank you.
Thank you. Take care, everyone.
Thank you.
Hope
Bye
to see you
bye.
tomorrow as well. Thanks. Bye.
Bye.